As introduced by Veronica, I'm in the department and I head up the policy area that deals with cancer control other than the prevention and screening area and the palliative care areas. And I've been asked to have a brief chat to you about some of the policy context for the piece of work that you're actually engaging in today, or the program of work that you're participating in. And as Bob said, government is very interested in optimal care pathways, and you will all know about the Victoria's Cancer Plan, which was released in July 2016. And I've just got a snapshot of the actual cover of that document, but it sets out the Victorian Government's policy agenda. And if you actually look at that document, you will see that the tumour summits and the implementation of the optimal care pathways are both very much embedded into the relevant action areas of that document. This slide also just emphasises some of the key principles that the plan is underpinned by, including, I think some of the things I would highlight are the care pathway approach, quality and safety, and equity. They're very key principles. So in terms of how we're actually trying to go about implementing the policy reform agenda from that cancer plan, we are focusing very much on optimal care pathways as a very key tool to enable us to do a whole lot of quality improvement and reform pieces of work. And this slide just is trying to encapsulate a number of those key pieces of work and demonstrate perhaps how they actually all work together to achieve the implementation of the optimal care pathways, which is, as I said, a key component of the cancer plan. So the tumour summits and the data analytics sit very nicely together, and this is your opportunity to have a look at what the data is telling us about how care is delivered across the state and where there may be variation that could be amenable to change. We have in the past also undertaken pieces of work around service redesign, and our integrated cancer services, of course, are key in supporting services to do improvement work. We are conscious of the consumer voice, and it is great to have a consumer here with us today. We've also been conscious of the interface, and we know that transition points are often where things can go wrong. And so we have had a focus on primary care, and there's been a piece of work led by the Cancer Council and the University of Melbourne called iPaste, which is academic detailing with the primary care practice staff, including GPs and practice nurses, etc., which is trying to introduce the optimal care pathways, risk assessment and referral pathways, and embedding the health pathways sort of referral processes. So that's sort of supplementing the work that then you will need to do. We also have funded some roles within primary health networks to again work specifically with primary health practices, so they can reinforce messages around screening and around referral pathways, and making sure that patients get to your specialist services as quickly as possible. And there is also the health services themselves have included implementation of optimal care pathways in their statements of priorities. Not all of them, but quite a number have. And that just reinforces, I guess, the importance of this and gives you an authorising environment. So specifically around the tumour summits, this is a little bit of history for you. As indicated, this is the 6th tumour summit, and the ones that preceded it are on this display. So we started with colorectal and lung fairly closely together, and that was because of some work we'd done which had identified some real variations in those tumour streams in terms of outcomes. So for example, in colorectal there's a 20% differential in terms of mortality for regional Victorians compared to metropolitan Victorians. Lung cancer, pretty obvious, and that was all part of a pilot, which is why we've had a bit of a gap to the implementation of the optimal care pathway through the integrated cancer services and some other pieces of work. But once that pilot had been undertaken and an evaluation done which confirmed the value, the sector felt that the tumour summits offered, we've now started to regularise this, and we are making a very explicit connection between the tumour summits, the engagement with the sector and that partnership around exploring the data, coming up with ideas, and then an optimal care pathway statewide implementation program. So the prostate and the esophageal implementations will commence, their preliminary work is happening now, so they will really kick off in the very near future. This is following their tumour summits, which were a little while ago. So I think what I'm trying to emphasise that there is a a broader plan of how the work that you're going to contribute to today fits within that whole framework, but it's not a quick fix. We all know that sometimes change takes time, and we just have to continue to prosecute this, chipping away to make the gains that we need to make. And that's simply what this slide tries to illustrate, and it is about trying to give you some sense that we've got the pancreatic cancer identified as a priority. The Clinical Working Party members are here today, and now the summit in November 2017. And if we project out, we can look to implementation at the statewide level through the OCP implementation later next year. So it gives us plenty of time to do the thinking that we might need to do, any supplementary work that we need to do to make us ready to do that implementation. And in terms of what we can hope to see as a result, this is just a couple of examples that I've got from some previous work done around the implementation of Tumour Summit recommendations or work following optimal care pathway implementation. So both of these examples are from service redesign work. So we have one from Grampians where the introduction of a region rapid access lung lesion clinic really truncated the amount of time taken between diagnosis and commencing treatment this case study shows two individuals, same disease, same outpatient clinic, but quite different experiences following the introduction of that clinic. And the last little example is, I can see Rob in the room, so this one's from the Bendigo region. We're looking at the quality of referral data and how that can make a difference to the triaging and therefore the timeframes for patients to get into the system. And I'll take you to the second one in the box. Just point. This one here. So you can see that pre the implementation, the percentage of positive FOBT test results that are included in the referral was only 31%. Post, it was 74%. So a significant shift that will translate into reductions in time between, for that patient to actually get in and have their colonoscopy, and therefore hopefully will influence their health outcomes. And that was all, but I did want to reiterate Bob's comments in terms of thanking NEMICS who are taking the statewide lead on this project, but also all of the community and the working groups who have been so generous with their time and energy in looking at the data and sifting through it to make a coherent discussion for you here today, a presentation that will lead the discussion, and who will also have a job post, so I'm putting in a plug for the next piece of work that you guys will need to do in terms of looking at the recommendations from this group. And I thank you all for being here and contributing, and more power to you.